Hi, this is Dr. Bernstein with our August 2019 teleseminar. Before we begin, I want to give you a couple of warnings. First of all, if I answer a question and give medical advice, it's generic advice because I can never know the entire medical history, nor do a physical exam on the questioner. So I don't really know him. And the suggestion I make may be totally irrelevant or improper. So the game plan here is to educate the listeners or the listeners in general and maybe have an answer that makes sense for the submitter, but it may not be right. So you cannot count on these answers. You have to consult your doctor. One other little caveat. We get hundreds of questions each month, and many of them have to be skipped because we don't have the time. However, the bulk of the questions are already answered in my book, Diabetes Solution. For some reason or other, the majority of the questions we get are people who are too lazy to read a book, and most of the questions are answered in the book. Before we start answering questions today, I'm going to cover a special subject, namely the fact that many of the people who send in questions are told by their doctors that they have to reduce the protein in their diet because protein is bad for the kidneys. This happens over and over, and I'll tell you a little bit about where this came from and my involvement in this. The hazard of proteins was initially set forth by an investigator in the 1970s and 80s named Barry Brenner of Yale. And he appeared at a meeting of the New York Diabetes Association, which was a chapter of the American Diabetes Association, around 1985, maybe 1984 even. I was freshly out of training, and I had just applied for membership in the professional section of the New York chapter of the ADA. So my application required that you be practicing for at least a year. So it must have been 1984. I had been practicing a year and submitted my application. And Barry Brenner comes to announce his great discovery with diabetic rats. He was on a tour, probably sponsored by Yale, to publicize this very important information. And it even got into the newspapers. If you have a publicity campaign and it's medical, you can get it into the newspapers. He had kept rats at a blood sugar of 250. And he had two groups of rats, those on a standard rat chow diet and those on a high protein diet. When he announced the diet, the blood sugar clamping at 250, he said that he got the target of 250 from the local physicians in, from the physicians in the ADA. And he got a consensus. and it looked like the ADA physicians liked blood sugars of 250 for their diabetics. And he asked the audience, would you guys all agree with this? And raise your hands if you agree. And everyone but me raised their hands. There were a lot of people there. And then he said, any people disagree? And I get up and I say that diabetics are entitled to the same blood sugars as non-diabetics. And I get booed for about a whole minute. And that was the end of my application for professional membership, because the meeting was held immediately after Brenner's presentation, and all the voters on membership were upset by my comment. Anyway, what Barry Brenner found is that those on the high protein diet died of diabetic kidney disease twice as fast as the rats on the rat chow diet. Well, I was around that time working on a study with a team at New York Hospital led by John Lariff, who was the guy who gave publicity to the role of the kidney in hypertension. And he's the fellow who developed the first ACE inhibitors, which is a class of drugs for treating hypertension and also kidney disease. And Lariff had a research fellow with him from Scotland. His name was Gordon Bell. And Gordon Bell was doing a study on atrial natriuretic factor, and he wanted to compare the poorly controlled diabetics at New York Hospital with my diabetics who were well controlled. My patients were the only well-controlled diabetics he could find in the country. So he was studying that. And 5 years after Brenner made his presentation, Bell makes a presentation to the National Kidney Foundation at their annual meeting in Washington, D.C. And lo and behold, he calls me from Washington that Brenner made a presentation, and that Brenner's presentation was made this time with rats at normal blood sugars. I guess he kept them at around 100. And there, all of the rats lived normal rat lives. None of them developed rat kidney disease. The study did not get published in any journal except the archives of that meeting, where it was just an abstract of the study. And there was no publicity campaign to spread the word that the culprit is high blood sugar, not high protein. So that's the sort of thing that happens in research studies. And it turns out that this blaming kidney disease on protein is one of the myths, like the cholesterol myth. Now we can go down to our questions. I just finished reading my own endocrinologist's book, Diabetes 101, and to my horror, he's advocating a high carbohydrate diet and daily testing for ketones. I've been experimenting with a very low carb diet and was planning on bringing it up to him at my next appointment, but now I'm nervous for what I'll be met with. What's your advice for communicating with an endo that's following old ADA baloney. And he spells baloney correctly. Well, one thing you could try to do is give him a copy of my book. Unfortunately, most endocrinologists don't have time to read a book and really aren't interested in controlling blood sugars. The other option that I have is for you to get a kindly family practice physician who will take the time to listen to you and be more cooperative in the treatment of your diabetes. I don't know. You could also give him or send to him a copy of the video of this teleseminar where he hears the story that I just gave. Well, no, that's about protein. It's not about low carb. So it's really hard to get doctors to change their minds. I don't really know what to say. Type 1 for 1 year, low carbohydrate. I take 13 units of Tresiba in the morning and 3 units of bolus for meals. I exercise after dinner for 30 minutes on a treadmill. I eat dinner at around 6 p.m. every night. I find that if I go to bed with a blood sugar under 150, I always wake up hypo, usually with the blood sugar between 53 and 65. If I eat a snack before bed, my blood sugar will go up to 170 or 180, but I will wake up by blood sugars in the 80s and 90s. What's causing this? Well, first of all, the exercise before dinner might possibly relate to the lows overnight. Another potential problem is that you're taking Tresiba insulin in the morning. And by, let's say you take it at 8 o'clock in the morning, by 2 o'clock at night, I would expect it to have worn off. But you're finding that you're going down overnight. Now, it happens that if you take large doses of insulin in one shot, you could make them last longer and possibly be giving yourself too much of a bolus. So let's say that you're taking 13 units and you only need, let's say, 10 units. If you give any dose of Tresiba, it should be morning and bedtime. And as we suggest for many type 1s, you take the Tresiba instead of in the morning, maybe 3 hours, 4 hours before you get up. So I take my Tresiba at bedtime and at 4 a.m. That gives me an even pattern throughout the day. But if you're taking it all at once, it could well be because of the large amount injected in one site. It might be absorbed over a longer period of time. That's one guess. The other guess is I would certainly try 2 doses of Tresiba, smaller doses. I'd eliminate the high carbohydrate snack. And as I said, the Tresiba would be lower. That might possibly do the trick. What do you recommend for type 2 diabetes when metformin is not enough? Victoza, Jardiance, other? Well, first of all, I do not recommend the SGL2 inhibitors, which would include the Jardiance. The Victoza, Byetta, and Simlin have their major effects on curbing overeating. Their effects on blood sugar per se are relatively small. So if you are an overeater, then Victoza, Byetta, or Simlin, which are all related to GLP-1 production in the intestines, might be of value. There also are the thiazolidine diones, Actos and Avandia. They have frequently the property of causing fluid retention, but not in everybody. And I believe we did a video showing how to see if you're retaining fluid by looking for edema in your legs. And if they don't cause, in your case, if they don't cause fluid retention, they're good candidates for keeping blood sugars down. And insulin always works, but it has to be used properly. Another reason for reading my book. What do you tell your patients in how quickly to lower their A1C with relation to retinopathy worsening? Well, what I tell them relates to a blood test for IGF-1. If IGF-1 is elevated and you already have retinopathy, it's been shown that you can make the retinopathy worse if your blood sugar is lowered rapidly. Now, how rapid is rapidly? From what I recall of the study, it did not indicate how fast you go from what blood sugar to what lower blood sugar. So it's a warning to be cautious if your IGF-1 is already elevated. So certainly if you have retinopathy, your doctor should test you for IGF-1, and then if it's elevated, you lower the blood sugar slowly, not suddenly. Here's something that works for me for appetite control. I chew a combination of sugar-free gums and drink plain iced tea or sparkling water at the same time. And this creates a stopgap measure for appetite between meals. It forestalls further eating for the time at least. Is there anything about this practice I should worry about? I'd only be concerned about the quantity of sugar-free gum. I once had a young lady who chewed 50 sticks of sugar-free gum per day, and I couldn't control her blood sugars because each stick contains 1 gram of slower-acting carbohydrate. Otherwise, if this works for you, that's fine. Our insulin lasts too long for me, even with a pure protein meal. What do you think about using Novolog after the meal instead? It's an interesting question. And I would say that it depends on experimentation. It's very rare that I find that the R insulin lasts too long. Now, it could be that this person is eating a high carbohydrate diet and that his blood sugars are uncontrolled. I should have said his or her. That's a real possibility. So I would think that you read my book, go on a low carbohydrate diet, you'll have much better blood sugars, and the R insulin will probably be working properly. And you could adjust the time of the R insulin before the meal to some people require it 20 minutes before a meal, some 40 minutes, some 0 minutes, some 70 minutes, some after the meal. So you could experiment with the R insulin at various times before or after the meal and see what happens there. On the other hand, if the Novolog works better, you could experiment with timing of the Novolog. Because the Novolog is more potent than the R, it's harder to measure because a half unit of R is 3/4 of a unit of Novolog, et cetera, et cetera. Now, I usually do not answer long questions, but I felt very sympathetic to this parent and decided to answer this one. My 2-year-old son is enrolled in TrialNet's monitoring study due to the fact that my husband has type 1 diabetes. At his 1-year-old monitoring oral glucose tolerance test, he had 1 antibody present, and at his 2-year appointment, he had 3. Within a month of learning he had 3 antibodies, we started your diet regimen along with my husband, and we do not waver from it at all. His blood sugars range between 60 and 80, mainly in the low 70s every day. And these are reasonable for children. A 2-year-old probably is usually in the high 60s most of the time, non-diabetic. Last week we met with a pediatric endocrinologist for the first time. He was not opposed to the low-carb diet, but didn't believe it would help preserve beta cells. My question is, the endocrinologist encouraged us to participate in a beta cell preservation study to determine whether the drug hydroxychloroquine can prevent or delay disease progression in participants age 3 or older who have 2 or more diabetes-related autoantibodies and normal glucose tolerance. I am curious if you have heard of this study and what your thoughts are about it. Would you recommend getting involved? Well, first of all, I think you ought to ask the people who run the study if there are any adverse effects to the hydroxychloroquine. Also, I'd check the internet very carefully for adverse effects. And then it's your decision if you find out there are no adverse effects. If there are adverse effects, I would probably stay away from it. You also might want to check, would he be in the control group or the placebo group? And that your decision has to include that information, because if if they tell you, well, it's a double-blind study, you won't know which group he's in, you may not want to participate if you don't know which group he's going to be in. Is berberine as effective as metformin, and would this also be safe to take during pregnancy with a prenatal vitamin? I've been prescribed metformin in the past, but it was giving me headaches and I didn't feel good taking it. I am not currently pregnant, but planning to be in the future. Berberine can help blood sugars, but I'm willing to bet that there were no studies to see if it's safe during pregnancy. You could check the internet to see if you could find any studies in the scientific literature. And if not, I'd say to play it safe, you'd be wise to use insulin. Insulin always works, but you have to use it properly. And therefore, you should read my book, Diabetes Solution, to learn how to use the insulin. My waking blood sugar is usually about 115, but about 1 hour after taking this, I'm usually about 30 to 40 points higher before eating or drinking. Exercise will further increase it. I'm 76 and have been type 2 for about 20 years. I am currently taking 1,000 milligrams of metformin. Is there a solution for me? I know that like this, I will never get my blood sugar to 83. Okay, first of all, read my book, Diabetes Solution, because this is a very common problem. It's called the dawn phenomenon. It's described in the book. And we frequently use a small amount of rapid-acting insulin on a rising. For type 2 diabetics, I just spoke to 2 type 2 diabetics today, both of whom are taking diluted rapid-acting insulin on a rising to prevent the dawn phenomenon. So that's one very good possibility. Now, another possibility is to use rapid-acting metformin as soon as you wake up, instead of the slow release, which is the likely one that you're getting. The rapid-acting works faster, but my guess is that it probably will not work fast enough to prevent the blood sugar rise. It might work fast enough to prevent the blood sugar rise from the exercise, maybe, but insulin always works. Problem is you have to know how to use it, and that's why the book. My daughter's numbers are all over the place, either high or low, very few in range, looking into trying to regulate better with carb control. However, she loves ice cream, and that would crunch her interest. I don't know what that means. She's 11 and already feels like she's so different from her friends. I'm not a fan of artificial sweeteners, so trying to get her to like sugar-free ice cream is not going to happen. Well, I don't know of any truly sugar-free ice cream. They put in sweeteners usually that are slower acting sugars like sorbitol. Let's see. What would you suggest for carbohydrates per meal for a preteen, and how can we work ice cream into her day? She currently eats a cup at a time, which is 38 carbs. Now, 38 grams of carbohydrate would raise my blood sugar 475 milligrams per deciliter. Is this really what you want to be doing to your daughter? The treatment of type 1 diabetes is a family affair. In my family, I was the type 1 diabetic, but because we didn't want my kids to develop diabetes, the whole family was on a low carbohydrate diet. And my kids, who are now older than I am, are still on low carb diets. So I would think that the very first thing you have to do is put everyone in the family on the same diet as she's in, so she doesn't feel like a freak. And there are little tricks that you can do, one of which I think I mentioned in my book. I had a 3-year-old girl who didn't want to give up her ice cream, and the mother made a mixture of heavy cream and Da Vinci sugar-free cookie dough syrup. And she and her friends liked her version of ice cream better than the store-bought ice cream. So her friends would come over to her house to get the special ice cream that the mother was making for her. Is it safe for pregnant diabetics on insulin to take fat-soluble prenatal multivitamins during pregnancy? Well, I'd certainly suggest that you speak to your perinatologist. There may be some vitamins that should not be taken during pregnancy, or should be taken, if taken, should be kept to very small amounts. So talk to your perinatologist. My cholesterol levels recently showed high HDL and low triglycerides, but my endocrinologist is concerned that my HDL is not protective because of my type 1 diabetes. I have been following the dietary recommendations in your book, Diabetes Solution, and now maintain an A1C of 4.9. Should I be concerned about my high HDL? A high HDL is protective, and your type 1 diabetes has now, in effect, been nullified by normal blood sugars. And in any event, his comment that a high DHDL is not protective for diabetes is not supported by any of the studies in the literature. What one does find is that elevated blood sugars contribute to heart disease, and even if you have a high HDL, if you're going to have high blood sugars, it's not going to totally offset them. My daughter was diagnosed November 2018 with type 1 diabetes. She's on Lantus 2 units at bedtime and Humalog with correction per sliding scale and carb counting. We are following your recommended low-carb diet, but clearly they're not following my regimen because we don't use a sliding scale or carb counting. We're following your recommended low-carb diet, so we are giving her only 6 grams in breakfast, 12 at lunch and dinner, and no correction, since our blood sugar is always between 80 and 120. Now, this person does not tell the age of her daughter, but most kids have blood sugars, non-diabetic kids have blood sugars in the 60s and 70s. So 80 to 120 is a bit on the high side for most kids. Any recommendations on how to prolong this phase? We are using Dexcom G6. Any thoughts or advice on this type of CGM? Well, first of all, I would suggest that you read my book, Diabetes Solution, and use insulin the way we do it in a more physiologic fashion. I also would suggest that you cut the carb for each meal in proportion to her body weight. What we say in the book is recommendations for an adult who weighs, I think, 140 pounds. So if she weighs 70 pounds, you cut the carb in half. If she weighs a third less than 140 pounds, you cut the carb by a third. And this is all covered in my book. Also, you have to make sure that she's getting enough protein. Most type 1 diabetics who come here for the first time are not getting enough protein. May have to do with ADA guidelines and deceptions, but they need enough protein to grow. If they're exercising, they need protein for that. If they're doing a lot of physical activity, playing outdoors with their friends, they need enough protein to cover that. So you have to be careful to give kids enough protein. I can't give you guidelines for that in this talk, but that's pretty essential. Also, children may need diluted insulin. We go over that in the book. Unfortunately, none of the long-acting insulins that are on the market can be diluted, so there are problems there. But read the book. 50-year-old female, diagnosed with diabetes type 2. Taking Janumet twice a day and 5 milligrams of glipizide once a day. Is there any way how I can control this high blood sugar? It's around 168 to 100 milligrams after meals. Well, the thing to do is read my book, Diabetes Solution, and follow the diet that it recommends. You could also get my book, Diabetes Diet. I do not recommend glipizide to anybody because it burns out beta cells and also has a record for increasing the incidence of heart attacks. And what would I use instead? One can use insulin, but you have to know how to use it. So that's another reason for reading my book. My boyfriend is 75. Well, he's not a boy. Well, he's a boy compared to me. The VA tells him as long as his BG is under 140, he's fine. His last A1C was over 7, which is an average blood sugar of about 180. He says you must be wrong because his doctor and the internet must be right. I've read your books and believe you. A former friend lost 2 legs due to diabetes and then died. He didn't believe you either. If the American diabetes people don't agree with you, how can I help my boyfriend understand that his numbers are too high? Well, what you could, one little trick that you could do is ask him to get an X-ray of his ankles. A simple X-ray, doesn't have to be a CAT scan or anything like that. And the radiologist, in all likelihood, will find calcification in the arteries of his feet, or the arteries of his legs near his ankles. And you could show him that his blood sugars have already caused calcification of his arteries, and maybe that'll wake him up. It's called Munkeberg's atherosclerosis. My grandchild is type 1 diabetic for 1 year. He is assuming he's receiving low-dose naltrexone for 2 years. How long can he keep taking low-dose naltrexone? If it's really low dose, it probably is not going to do any harm, and he could take it for indefinitely. Why he's taking it, I have no idea. But if it's truly low dose, like under 5 grams, I don't think it's going to do any harm. My 17-year-old son was diagnosed with type 1 2 years ago. He is naturally thin and very active, runs cross-country and does weight training most days. We're having trouble getting him enough calories to maintain his growth, 2,500 to 3,500 per day, on a low-carb diet. Do you have any suggestions? Your book's discussion of calories mostly seems to focus on people who need to limit calories. Well, the research shows that kids need certain amounts of protein to grow. And the protein which are usually prescribed in grams per kilogram of body weight per day. That's grams of protein per kilogram of body weight. And also they need insulin. So you have to make sure that he's getting enough insulin and that he's eating enough protein. Very important. And as I said, it's hard to tell you how much is enough. You might want to consult with a really well-trained nutritionist. It's unfortunate that many of the nutritionists that I've encountered advocate the ADA high carbohydrate diet and sort of ignore the proteins. I've been on insulin since 1965. In 1986, I found your book, The Glucograph Method for Normalizing Blood Sugars, just in time. No complications that my endo and retina specialist can find. My sister also has been on insulin since 1968. We both acquired type 1 at exactly age 35. Have you heard of this? Is there reason or just coincidence? We have no other siblings. Well, my guess is coincidence, but there may be things happening out there in the interdimensional world that are focusing on you that we don't know about. But my guess is coincidence. Male, 39 years old, diagnosed with type 1 diabetes at age 32. Maintained tight control and followed your book with A1Cs in the mid to high 4s. After a period of chronic stress in 2016, I experienced a myriad of symptoms, including low libido, low body temperature, and loss of taste and smell. I have had my testosterone checked numerous times. In each case, total testosterone is high, free testosterone is low, and sex hormone binding globulin is very high. What can cause this and how can I treat it? Well, the high sex hormone binding globulin can bind testosterone and thereby lower the free testosterone. So that jibes with the high total testosterone but low free testosterone. The low body temperature may relate to low thyroid, low free T3. So it might be a good idea to test your free 3T3 triiodothyronine to see if you're hypothyroid. It would certainly be a good idea to consult a reproductive endocrinologist who would look at the testosterone situation. Age 35, type 1 diabetic. I committed to a low-carb diet under 30 grams carb per day in the last year. I have a family history of hypercholesterolemia, and my lipid panel this fall showed my LDL has skyrocketed from 170 to 267 in 1 year. Was this change your recommendation regarding going on statin therapy? Wait, would this change your recommendation regarding going on statin therapy? Well, I don't think I've made a recommendation about your going on statin therapy. I'm really hesitant to start statins due to all the bad press, but it seems unavoidable due to my family history. Well, that's a very good point. One thing that you might want to do is find out if your family with a history of hypercholesterolemia has tried statins and whether the statins made a difference. Also, what is the hypercholesterolemia? Is it just an elevated LDL, or is it an elevated small dense LDL, or elevated oxidized LDL? So I think it's first a good idea to know what kind of LDL you have, small dense or large buoyant. If it's large buoyant, maybe you shouldn't be worried. Also, you should be looking at inflammatory markers like C-reactive protein and a few other inflammatory markers, because the effect of statins on reduction of heart attacks correlates with their reduction of inflammation, not with reduction in LDL. So in the latest portion of the Framingham study, they found that statins did increase lifespan in people with high levels of inflammatory markers, but did not, but their effect on LDL had no effect on lifespan. So what we're mostly concerned with is inflammatory markers. And your cardiologist should know what inflammatory markers to test. One of them is C-reactive protein. There are others to test, fibrinogen, and a few others. Oh, LP small a. LP small a is very important. And if you're a woman, it can be caused by estrogen deficiency. In my experience, LP small a is the most important risk factor you could measure in the bloodstream. This person belonged to a large medical plan that had been treating him for many years, and he was getting insulin. He was being treated by one doctor for all this time, and he got his blood sugar, his A1C into the normal range, was on a low carbohydrate diet, and the doctor retired. Couldn't be found after his retirement. 2 new doctors came in on the case, and they saw his A1C and said he couldn't be diabetic. They couldn't prescribe, they would not prescribe insulin for him. Now he wants to know what to do. So I said he has to get away from this group and find a kindly family practice, a physician who would listen to him, but he also has a right to his medical records and has to demand that the insurance group turn over his medical records. This is a combination insurance group, medical group. And you always are entitled to a copy of your medical records and all of the tests that you get. You get any radiographic tests, you're entitled to a copy of the film or the CD where they recorded digital data, and you're entitled to a copy of the radiologist's report. Likewise, laboratory results. I take metformin, 500 milligrams of the extended release, morning and supper. My endocrinologist put me on that to help with dawn readings. Is it never indicated to use is it ever indicated to use one fast-acting metformin and one extended release? Yes, I've used combinations of both for many patients. The supposed upper dose for the extended release is 2,500 milligrams per day, and for the rapid release, wait, I got it backwards. For the extended release is 2,000 milligrams per day, and for the rapid release, 2,500 milligrams per day. So if I have a mixture of the two, I might go for a total dose that's in between 2,000 and 2,500 when I need the maximum dose. There's no harm to mixing the two, but you have to have a purpose for doing it. Here's the first page of the other question. What is the latest glucose meter you recommend? I've had issues for the past week with my Abbott Freestyle Light meter. Well, if it's only for the past week, you could check the battery, replace the battery. You could also, you may have come across a bad batch of strips. So try another batch of blood sugar strips, hopefully with a different lot number. I've never seen the Abbott Freestyle or Freestyle Light meters change except if they've been injured or damaged. For example, keeping them for a long time in the heat can adversely affect the display, liquid crystal display. I don't know what very cold temperatures will do long-term to them, to the electronics. So it is possible that it's received some sort of injury, but the meter is the one I currently recommend. That is the Abbott Freestyle Lite or the Freestyle. What is your experience and or opinion of Trulicity being advertised on TV? This is a once-a-week injectable GLP-1. It's much longer acting than, let's say, Victoza, which is recommended for twice a day, or Byetta, which works for about 6 hours. But to me, I see no purpose to it. The GLP-1 agonists achieve the bulk of their blood sugar effect by reducing overeating. They reduce appetite, and they reduce it for a period of time. For some people, they'll work indefinitely to curb the appetite. For others, they might be good for 3 months. For others, might be good for a year, and then the excessive appetite returns. But if you're treating the appetite continually, bombing receptors for the GLP-1 continually day and night, as the Trulicity does, you really get adapted to it almost instantly. And I've not seen any effect upon appetite of the Trulicity. So its effect on blood sugar is going to be minimal, might affect A1C 0.3 of a unit or even less. What is your opinion of the Freestyle Libre sensor system for measuring blood glucose? I frequently find that the numeric value from a sensor scan is lower than a finger prick value taken at the same time. Well, first of all, I don't like the Freestyle Libre system because it doesn't give you any alarms. The reason I use a continuous glucose monitor is to alarm me, to let me know if my blood sugar is too low, to catch hypoglycemia. Most of my blood sugars are in the narrow normal range, but sometimes they get too low. I want a warning about that, especially if I'm sleeping. Well, the Libre will not give you any warnings. You have to wipe your receiver over the sensor to get a reading, and for that you have to be awake, and you have to also, if you are awake, be desirous of getting a blood sugar reading. Well, you may not know that your blood sugar is low, and you may not be prompted to get a reading. So what's the value of the whole system? Now, all of the continuous glucose monitors are going to be reading not blood glucose, but interstitial fluid glucose at the site where the sensor is installed. But the interstitial glucose level is typically 20 minutes to 30 minutes behind the actual blood glucose reading. So if you're dropping rapidly, you can expect the sensor to be higher than the actual finger stick. Or if your blood sugar is increasing rapidly, you could expect the sensor reading to be below the finger stick. If your if the sensor is accurate, you can expect that a steady blood glucose level, the sensor will match the finger stick because you've had longer than a half hour for it to catch up with the finger stick readings. So all in all, as far as CGMs that are currently on the market, I prefer the Dexcom. What is your opinion of Tresiba long-acting insulin? I discovered that compared to 10 units of Trejeo, which is Lantus, 8 units of Tresiba works, and that Tresiba is better for overnight blood sugar control. Well, that's why I've been recommending Tresiba for several years now. And the Trejeo, unfortunately, is the same as Lantus, glargine, and this is the insulin that has 165 times the binding power to insulin-like growth factor receptors than human insulin, and therefore is likely to stimulate the growth of cancer cells. What is your opinion on a Fretsaw inhalable insulin? Well, I think I've commented on this before, but I'll do it again. The problem with a Fretsaw is that you don't know how much you're going to absorb. Every time you inhale it, a different amount gets absorbed. So there's unpredictability. That's the downside. On the upside is the fact that it's very rapid. So if you're a type 2 diabetic and may require a small amount for a meal, you might find that you can get away with 1 puff of Fretsaw. Supposedly, 1 puff is equivalent to 4 units of ordinary insulin, but which is maybe a lot for some type 2 diabetics, so it might be too much. I have only 1 patient who is a type 2 diabetic. He's a fellow who travels all over the world constantly as part of his job, and he doesn't like the idea of taking out a syringe and injecting himself in public places, even on an airplane. And what he eats is unpredictable too, which makes it very hard for him to follow my regimen. He's really doing his own thing. And because of the simplicity, he prefers the Fretsaw, but he does not get normal blood sugars. He tries to keep his carbohydrate down, but he can't get normal blood sugars, and he's the only one I'm treating who uses it. Well, we're now going to be meeting again in a month. Our next teleseminar is Wednesday, September 25th, 2019. Thanks for being with us tonight, and we'll see you in a month.